All right. Hi, everyone. My name's Mandy Ashley. I'm the director of the Aurora Health Alliance, and welcome to our virtual behavioral health series. In this series, we're covering vulnerable populations during COVID-19. First, I wanted to say that this is sponsored by Colorado Access and Signal Behavioral Health. So thank you to those amazing organizations for your support. If your organization is interested in sponsoring this event or any of the other Aurora Health Alliance events, please do let me know. Thanks also to AHA staff and our volunteer planning committee for getting this series off the ground so quickly. I would just ask, I know we're all living in a land of Zoom right now, but just a reminder to mute if you're not speaking. This is the second of 4 events in our series. Today we're focusing on seniors and older adults. The final 2 events are the next 2 Wednesdays at noon, where we'll be focusing on substance abuse disorder and a topic to be determined this week. We've left that topic open because we wanted to hear from you all on a vulnerable population you'd like us to focus on. We've received a couple since last week's series, but if you have suggestions for that, you can drop a note in the chat box or email info@aurorahealthalliance.org with any suggestions. Following this event, like right after this event, we'll be sending out a short survey. We're trying to measure the success of this web series, so your feedback is definitely appreciated. I'd like to introduce our 3-member panel. Each panelist will present for about 10 minutes, and we'll wait for questions at the end of the entire panel. If you have those questions, please enter them in the chat function as they come up. So, and then panelists, I have all of the slides, so if you want me to advance slides, just let me know. First, we'll be hearing from Catherine Baines, licensed marriage and family therapist with the Health One crisis team. Our middle panelist will be Evan Kliss, PhD, who's a postdoctoral fellow in palliative care and aging at the University of Colorado, Denver. And finally, Rebecca Case, licensed clinical social worker and RYT, which after a quick Google search, I think is a registered yoga teacher, but you can definitely tell us more during your presentation. He's with HeartCentered Counseling. So, Catherine, you can go ahead.
All right, thank you so much. Appreciate it. So I'm a licensed marriage family therapist on the Health One crisis team. I've been there since 2016. We do evaluation in 16 emergency rooms for Health One. And those evaluations are usually for and around mental health issues, people in crisis. We do see quite a few seniors. I usually get the seniors because my background as a case manager, working for Health One for 15 years in the Denver metro area. So where I'd like to start is in February 2020, the National Academy of Sciences, Engineering and Medicine released a report on the effects of loneliness and social isolation on older adults, which found strong evidence suggesting many older adults are socially isolated or lonely in ways that puts their health at risk. And for seniors who are homebound, have no family, or do not belong to community or faith groups, according to the report, a medical appointment or home health visit may be one of the few social interactions they have. Furthermore, the report cites social isolation and loneliness may also directly stem from chronic illness, hearing or vision loss, or mobility issues. I would add speech issues to that as well. The news release for this report was dated February 27th, 2020. The first case of suspected local transmission in the US of COVID-19 was February 26th, 2020, one day earlier. In a few weeks of the release of that report, the general population of the US began the process of isolating at home in response to the pandemic. And seniors in particular will be and continue to be encouraged to isolate because the statistics show they are among the most vulnerable to this disease. During this time, the seniors I have evaluated through the Health One Crisis team have predominantly expressed fear and hopelessness. For some, messaging intended to keep them safe, such as wear a mask, don't touch your face, social distance at least 6 feet, rather than communicate the intention to educate about reasonable measures to take to stay safe, these messages invoked a sense of foreboding. These messages appeared to validate what the senior already felt, that the world really is a dangerous place. For some of these seniors, the hospital was no longer viewed as the safe place it once was. This is particularly important for those seniors who lacked access to mental health providers and who would go to the emergency room for that help. It is of note, the number of people my team evaluates decreased significantly since the start of COVID, which means people who need help aren't seeking it. And those who do present to the hospital are afraid to stay. Even when it was medically necessary, they remained out of fear of contracting COVID. I have also seen several homeless seniors, I'd have to say predominantly male, who reported the places they used to go to for support, such as the mental health center, or local gas station, or a fast food restaurant where they would go to use a restroom, were closed due to COVID. These men essentially did not know where to go. They were at a loss. And I'm aware the homeless shelters are open and offering wonderful services. There is a segment of the homeless population that doesn't take advantages of those services. They prefer the informal systems. And it is also of note, these men, when I was done with my evaluation, wanted to leave the hospital as soon as possible, again, for fear of getting COVID. So for those needing to see a doctor or mental health provider without going to the emergency room, technology has come to the rescue with telehealth. In addition, Zoom, which offers ways to connect with exercise, interest groups, and discussions, help serve to minimize the effects of isolating at home and loneliness. But while these options are available, some seniors continue to have issues understanding how to upload the apps and how to manipulate the technology, which is resulting in some limited engagement, especially for those with visual, hearing, and speech issues, as well as cognitive impairments. Also, frankly, some seniors are simply not comfortable discussing the private details of their health over a video monitor. Others simply can't afford to have internet. According to HomeCareAssistanceDenver.com, 10% of Denver's senior population have an income less than $10,000 a year, and 30% have income less than $20,000 a year. With that kind of budget, access to internet in the home is a luxury. And for those in the mountains, potentially not an option due to connectivity issues. So while the focus on telehealth and Zoom in the media has had a positive effect in that some seniors are willing to try online doctor visits, exercise classes, support groups, etc., and explore this new technology, it falls short for those living independently who might not be able to afford online access, who are not technologically savvy, and or who, as stated before, have vision, hearing, speech, or cognitive issues. These seniors may have to rely on the community, family, and or friends for support. However, in my experience, these fragile seniors can be resistant to that support they need. Sometimes they feel that it's like an intrusion in their life. If you think about it, They're essentially told to reveal the private details of the food they eat, the personal items they use, the budget they have, all in the name of ensuring their personal safety. It seems the more seniors are told to isolate, the more public the details of their life becomes. A New York Times reporter, Paula Spann, wrote an article published in the New York Times last month, "What Older People Didn't Need, More Isolation." She writes about the findings of that report I started this with. She also writes about how, after closing due to COVID, a YMCA in New York reached out to all 650 senior patrons on a weekly basis. Each YMCA staff person held a caseload of people to contact every week to keep in touch and encouraged them to use the digital programs created especially by the Y for their senior population. What struck me about this approach is it rebuilt routine for those seniors. The connection the seniors had with their local YMCA continued, and in a routine manner, with the local phone call the senior knew they would get. Routines are not merely a series of meaningless tasks. A routine is made up of choices that reflect the person's value base. Routines reinforce feelings of safety and well-being, and a positive routine serves to offset isolation and loneliness by building social connection. So as I was thinking about this, it underscored for me how connection in and of itself is not enough. Connection needs to be meaningful for it to be effective. And I believe connection occurs best in the context of a routine, because with a routine, that connection becomes meaningful. So something as simple as going to the grocery store every Monday morning means likely interacting with the same people who work at the store on Mondays. The senior becomes a part of the worker's Monday routine as well. So there you have a type of social relationship, a reliable connection. This type of informal community connection is especially important when many seniors are experiencing a decreased connection due to retirement, physical limitations, and/or the loss of loved ones to illness. All of these of which are breeding grounds for isolation. So having to change a routine by not going to the store, not going to church, not going to the Y is a big deal. It means having to change what is valuable to that person. It is a loss. So when the Y staff outreached the seniors by phone, they reestablished a meaningful routine and communicated to the seniors they matter, they count, they're thought about, and they're seen. So what to do? So in addition to utilizing, okay, so this is my last bit. In addition to utilizing outreach in order to maintain connection with seniors when they can no longer participate for reasons due to the pandemic, I think it can be helpful to ask questions rather than dictate to the senior what they should do. So questions such as, what was it about that routine they found most helpful, most valuable? What is it about technology that is concerning, scary, difficult? What is the hardest part of this change? To engage the senior in a conversation, in my experience, helps the senior open up to what's meaningful to them so that you can help problem solve how to reconnect them in a meaningful way so that that routine is reestablished and that relationship is reestablished. That's pretty much it. I have a little bit more. There are some, it was an excellent New York Times article, by the way, and I would encourage anyone to look it up.
So we received a question about, can you please share that article? So if you want to send it to us or if you want to drop it in the chat line, that'd be helpful.
Okay, I'll send it to you because I'm still figuring out this technology myself.
Well, thank you so much, and I'm sure there will be questions coming in at the end of the panel. My notes are long from your presentation, so thank you. I was okay. So thank you so much. Next up, we have Evan Pliss.
Thanks so much. Thanks so much for having me, and also for having this topic as well. So I'm really excited to talk with you about mental health and aging. So my background is actually in clinical geropsychology, and I specialize in mental health, aging, and post-acute and long-term care settings at CU. So on the next slide. So am I able to advance the slides? Or is that okay? So you're there. So I wanted to start off by talking about a framework that I think is really helpful when we think about mental health and aging during COVID. And this is based on the trauma literature, and there's this hypothesis called the stress inoculation hypothesis. And it essentially treats stress and resulting mental health conditions like a vaccine. And so a lot of individuals will be exposed to stress, and some will develop antibodies and then take those with them when they experience future stressors. And I think that this framework is particularly important for older adults, because if we think about the 7th, 8th, 9th decade of life, the majority of these individuals will have experienced major life stressors. They will have experienced adverse life events, crises, disasters, and the majority of them will have coped well with these disasters and built resiliency and resistance to the onset of mental illness. There's been research that shows that over 2/3 of older adults have experienced a life event consistent with a trauma. So even though COVID-19 is a completely new issue that we haven't dealt with as a society, our older adult clients and individuals in our community have experienced stress in their life. And the overwhelming majority of them have coped with this stress and built up strengths that they take with them when they're dealing with stressors related to COVID-19. So I think one of the key points here is when we're engaging with older adults and we're asking about psychological distress, it's really important to assess what are the strengths that they've built up over the lifespan. What are the wisdom, the aspects of wisdom that they're taking with them to then cope with this stressor. Obviously, during a disaster pandemic like this, we're going to see an increase in distress and psychological symptoms. Sometimes we need to just connect people with what are the strengths that they've already built up. So to Catherine's point about asking questions, one of the questions that I always ask is, you're coming in, you're telling me that you're more anxious about your health right now. When have you been anxious about your health in the past? And what did you do then? The biggest predictor of behavior is previous behavior. And we can assume that a lot of the older adults that we engage with have experienced a lot of different behaviors in their lifespan that they can pull from, that we can kind of help them to pull from. The flip side of this is that there is a percentage of the population that has had adverse reactions to stress. So these are individuals that maybe have a history of substance use or PTSD, serious mental illness. And so those are the individuals that we might want to pay a little bit more attention to, screening, making sure that we're checking in to make sure that they're connected with services and not at risk. And so next slide. And so one of the cycles that I worry about and we see a lot with older adults is kind of this blending of psychological distress and physical symptoms as well. So in older adulthood, the way that things like anxiety, depression, grief, stress manifest a lot of times is in somatic complaints. So when an older adult is experiencing heightened stress, we might see an increase in pain, some sleep problems, less activity, more somatization of those mental health conditions. And so one of the cycles that I've seen a couple of times that I would expect we would be seeing and wanting to address during COVID-19 is having sleep disruption as a result of some of the stress and psychological issues that are going on during COVID-19, which then brings on fatigue, and either due to fatigue or having limited opportunities for exercise, we see a decrease in that and inactivity, which then brings on more fatigue. And then we add maybe a little confusion, and we might see an increased risk of falls. So I spoke with a caregiving group a couple of weeks ago, and we were talking about autonomy and support as a caregiver, and particularly during COVID-19, and as we've already talked about around hospitalizations, we want to make sure that we are addressing safety. And so falls is something that I would definitely worry about during this time, because we don't want people going to the hospital. So there are a couple different ways that we can intervene to disrupt this cycle. One would be addressing the underlying psychological distress through the strength-based approaches that I mentioned. Now is also a really good time to be checking in with good sleep hygiene. And there are a ton of resources online about how to alter our environment and control stimulus to make sure that we're giving ourselves the best shot of sleeping well. Two that I want to highlight are relaxation and meditation to kind of turn off the brain before sleep. So turn off the brain and also turn off the TV. At any time, television can disrupt our sleep, but particularly 24-hour news cycle. I know I'm guilty of staying up late watching TV, and it's just a disaster for trying to get to sleep. So making sure that we're turning off our minds and turning off the TV. Also making sure that we're engaging in safe activity, but continuing activity during the day. There are a ton of resources online about engaging in safe physical activity during quarantine. And then lastly, checking in with our older adult clients that might be at risk for falls and making sure that their environment is safe. So addressing things like rugs. Rugs are a huge culprit of falls. Making sure surfaces aren't slippery, or that people have good grips on their shoes or socks. And we're clearing clutter in the environment. Another big culprit of falls is getting up in the middle of the night to go to the bathroom and not having that path lit. So making sure that there's some lights between the bedroom and the bathroom if someone gets up in the middle of the night to go to the bathroom. And also just making sure that there's opportunities to rest or rails where needed in the home. And the last slide. And so the last thing I want to talk about is one of the unfortunate consequences that we've seen during COVID-19 is an increase in ageism. And so this has been displayed in the media around and memes online being shared calling coronavirus the boomer remover. Ads, as you see in the bottom right, around portraying older adults as frail and helpless, and a population that we need to support because they can't take care of themselves. And even more recently, I'm including some headlines of articles that I found that are really pitting older adults against the economy, essentially. And so now we might see, because of this, obviously everyone's experiencing a lot of psychological distress related to economic hardships. So I worry that we might see an increase in ageist behaviors and also internalized ageism amongst older adults. We know older adults are going to be hit very hard economically during COVID-19. They're going to have a harder time returning to the workforce or finding jobs if they've lost them. Retirement savings might be depleted. And so what does it mean for an older adult when you might internalize a message that I'm somehow to blame, or I feel shame around these economic hardships happening? So I think one of the key points as a group of individuals who are invested in older adults is that we're making sure that we're combating age stereotypes in our practice. One is to be really well versed about the stats around aging and COVID-19. So I included a table from the CDC, and we see, just like other groups, older adults are a really heterogeneous group. Being 65 and healthy looks very different from being 85, looks very different from 70 with COPD, and those have very different risk factors for hospitalization, ICU admission, and death due to COVID-19. So we really need to make sure that we're well versed on this information so we can combat age stereotypes when we see them, either from general adult populations or even internalized stereotypes from our older adult clients. I would also ask people, say, I've noticed that there's been a lot of discrimination against older adults right now. Is that something you've experienced? And start that conversation and normalize and make sure that they have an outlet to talk about that. Or even ask, has your views of your own health and age changed as a result of this? I've heard from other people that it might. So being supportive and allowing that outlet. And I think lastly, to close on this, that we also kind of have an obligation to combat age stereotypes in our own work, in the language that we use, in the appreciation of the heterogeneity of this group, and the intersections of being an older adult and socioeconomic status and age and health, and being really thoughtful about that, and also thoughtful about what we share on social media, and just being good advocates for age empowerment and quality, and making sure that we're not playing into this, because I do think that this is a really major, potentially a major risk that we might see in the future for older adults around the way that the media and society has responded to some of the issues here.
Thanks, Evan. I know that I don't think about my own sleep hygiene, even if I am sleep training a toddler right now. So that's a good reminder, I think, for all of us. We'll move on to our last panelist, Rebecca Case, and then we'll have some time for questions. Thanks.
Thank you. Mandy, you are correct. RYT stands for Registered Yoga Teacher. So namaste, everyone. Thanks for having me. I'm with HeartCentered Counseling. Yeah, Google finds it, right? So thank you, Evan and Catherine, for your wonderful presentations. And I'm sure I'm just going to reiterate some of the very intelligent points you've made and spot on. And I just want to start with kind of emphasizing Evan's last point around being aware of the stereotypes that we may fall into, and really being considerate of that. And I think one of the most important things in working with our senior population is never assume that you know what these individuals are experiencing. Start by asking, how are you doing? My mother, for example, is 70 years old and she lives at home alone. And, I check in on her multiple times a week, and she's just rocking this. Like, I could take a number of lessons and pointers from her. She says, I pick a song of the day every day that she posts on Facebook, and I call one person every day I haven't talked to in a long time. And she's doing all the free online classes and, touring the art museums that you can tour for free. And I told her, I need to create a YouTube channel for you or a blog. Like, you need to be teaching other people how to do this. And that's very much based on her own resiliency and her life experiences, right? Because our older adults at this time in their life, they've had a lot of other experiences, as Evan has already pointed out, right? And there's a great capacity for what we know as post-traumatic growth. So you don't get through this lifetime unscathed, right? We all get scarred and bruised and beat up, right? And how we have learned to cope and overcome or heal those past experiences is a great contributor to our later life resiliency and how we cope with adversity and this whole experience that we're all going through right now. So as one of my colleagues had pointed out, talking with older adults about, tell me about a time in your life in which you've overcome, in which you've persevered, and how can we pull on this part of you to help you cope with this time in your life. There is something that our older adults have that's a wonderful gift and a strength, and that is that they have extensive life experience. Right, so I read an article recently. I was trying to find it so I could actually quote it in today's presentation, and I just couldn't find it. I think it might have been in the Washington Post or the New York Times, but it was an older adult writing about, don't necessarily believe that because, we're older adults means that we're having a really hard time with this, because we have something that you may not, which is a lot of life experience to pull on. And some of our older adults may be able to say, this is by far not the worst thing I have lived through in my life. Right? So I think that it's just really important that we never assume what somebody is going through because of their social identity, and we really ask, how are you specifically experiencing this time? Now, certainly in the private practice world, heart-centered counseling is a large group private practice. We have offices in Northern Colorado, in Denver, and in Colorado Springs. And we are certainly seeing with our older adults some of the expected impacts of this time that I would say are not that foreign to what we're all experiencing, right? An increase in anxiety, an increase in worry, increase in intrusive thoughts, the strong desire to constantly be connected to the news and to the media, and constantly maybe be checking our phone, or we forget to turn off the news, a lot of fear, a lot of perhaps helplessness, some hopelessness, grief. We're all going through immense grief of changes to our day-to-day, changes to our relationships, changes to our structure, to our routine, as Catherine so eloquently pointed out earlier, right? And really what we're all going through is shared traumatic experience, and our older adults are going through a shared traumatic experience, and how we each experience that trauma and this change is going to be specific to our own life experiences and what life looked like before all of this happened. Now, certainly we know the reports as well that indicate, an increase in domestic disputes and domestic violence, and our older adult population is certainly no exception to that, as well as possible increases in alcohol and drug use. So I think that these are all pieces that as you work with your older adults, you're really asking, how are you doing? How is anxiety? How's your mood? How, are you drinking? Are you using your drugs, your prescription drugs as prescribed? What does your sleep hygiene look like? Are you using just basic skills to help calm and soothe yourself? What does your caffeine intake look like? That's a big piece too, right? Because sometimes we ask our clients, how much coffee or how much soda are you drinking? And if you're drinking 2 pots of coffee a day, there's not a whole lot I can do to touch your anxiety. So I think making sure that we're doing our due diligence to really ask these questions, and not only asking about what are the problems, where are the areas of risk, but as Evan had pointed out, what is working? How are you coping? What is going well? Who is in your life that's reaching out to you and supporting you? And where could we maybe increase some of that support based on what they're saying they need and what their goals are? So certainly some of the challenges we of course see are that this population who may have been more reliant on their doctor appointments or social get-togethers, the weekly bridge club meeting perhaps, bingo, getting together with family members, home health care workers, they may have limited access to those eyes on. And so that certainly poses some risk of, are the people who are having constant interaction with these individuals and have those eyes on, now there's additional risk of they may not be able to be monitored. So is there domestic violence going on at home? And if so, who's going to catch that and who's going to respond? Have they been susceptible to a scam? I know that we've all seen, it breaks my heart to see these scams that are specifically targeting our older adults that are in even more of an influx right now, right? So this is another challenge. Disruption to care, certainly, as I mentioned, is disruption to day-to-day routine. And then, of course, as Catherine also mentioned, technology. Some of our older adults are very comfortable with technology and could maybe even teach us a thing or two. But some are very hesitant and are afraid that the use of technology, I think as Catherine had mentioned, could be an avenue to be scammed or to be taken advantage of. So one thing that I have done, and I know heart-centered counseling as well, is that those clients who are discomfortable with Zoom or with online platforms to connect for a virtual session, is just starting with a telephone call. Right, because that can be a great place to build rapport. Our older adults and just individuals in general tend to feel more comfortable with starting things on the phone. And can you start to pave the pathway of a relationship and building rapport and connection with that individual, and then perhaps getting them set up on an online platform so you can actually meet face to face. So that can certainly ease their anxieties about using online technology, and also helps to build rapport so that they can feel trust with you and know that you're not there trying to scam them as well. Right. So I think another piece that's important with our older adults is outreach, outreach, outreach. And that is, we need to be outreaching the older adults that we know in our lives and checking in and making, you know, contact or connection when we can in a safe way. And then seeing about, you know, who in your life can outreach you. Who are you connected with? How about your granddaughter? What about your daughter? What about your friend next door? Right? And making sure that they're having connection and contact as much as possible. I think also making sure that we're asking those questions about just basic life skills and life needs, such as, you know, are you able to pay your bills? How have you been sleeping? What does your diet look like? How much is the TV on? How much are you getting outside to get some fresh air or getting some sun? And making sure that we're not discrediting or failing to examine those important just day-to-day adult living, daily living skills, and how important it is to assess for those. Our interventions as helpers, whether that's behavioral health professionals or case managers, always needs to look at all of the systems within somebody's life, whether that be psychological or physical, and then social connections. And in today's world, we have to get creative. And so I think it's important that we continue to look to each other as a shared community of helpers of what we figure out that's really helpful and supports this special population during this time. So those are the bits that I have to share. Thank you.
Thank you so much. Thanks to our panel, to all of you. I think some questions have come in through the chat. Joanna has been monitoring that, so.
Yeah, we do have a few questions that came in. This one is to Evan, and someone asked that currently there are home health agencies that cannot go into seniors' homes due to fear of spreading the virus. How should we weigh the risk of exposure versus the risk of seniors not getting necessary services or assistance with their needs? If they don't receive critical services in the home, does the risk increase for them to end up in the emergency room or hospitalized? So I think that's a good question about how to weigh that. Where's that kind of balance there?
Yeah, it's a tough question about the balance. You know, at what point do you have to, you know, go into the home to prevent, you know, a significant event from happening? I think thinking about the process, kind of the first line of defense is what can we do remotely? What can we do over the phone to keep people safe? You know, one of the things that's really nice about in-home care is you're not only providing care to the individual, but you're providing care to the environment and modifying the environment to keep the individual safe. That's, you know, kind of the benefit of that type of service. So one of the things that, you know, I've done in the past, not particularly remotely, but there's a lot of websites out there around assistive devices for aging in place. And there are blogs devoted to this, and I think there's even just like an aging in place technology website that you can go to, and a lot of them are really expensive, and I would never recommend like those products for my clients. But if you look at them and you search, then you can start to problem solve around, okay, well, what are some things that we can alter in the environment remotely that we can, you know, provide this information to try to manage everything in the home with, you know, the individual making these modifications on their own to prevent that significant event from happening. If there's cognitive limitations, I think that definitely complicates the image, the picture there, and that's a really tough question. I think organizations kind of have to weigh, but I would say the first line is to get creative, as you know, we talked about, that word has come up a few times, to get creative around what are some of the assistive devices that we can implement in leveraging what we have in the environment and giving our older adults the tools to change their own environment.
Great. Thanks, Evan. Another question that came in, and this, you know, if there's anyone out there who does kind of in-home programs in terms of installing grab bars or safety checks and things like that, how are those organizations protecting seniors beyond just PPE, but how are they protecting seniors and themselves when they're going into seniors' homes to do certain things? If they are, I know a lot of those programs are suspended right now, but some of those programs are continuing. And so if there's anyone out there that wants to answer what additional protective measurements are being taken if you are going into seniors' homes. Anyone? And anything that we have a couple minutes left, and we have a few more questions coming in. And if there's information or resources that you do want to share beyond this webinar, we can certainly help get that information out. Aurora Health Alliance does have a COVID-19 web page. So another question that came in, it said, Evan, you recommended that people don't use technology 1 to 2 hours before bedtime. What activities do you recommend, especially for folks that live alone?
So I'll give some examples, and I'm sure my colleagues can also provide some good examples as well. I think anything that doesn't involve, activating activities or things that are looking at a screen. So sometimes writing, reading, meditation is a really good one, stretching, things that really help winding down and then aren't, looking at a screen and getting that blue light activation. Also, sometimes just processing the day, writing things that you're grateful for, really preparing yourself to turn off that mind and get to sleep are all good activities. I'm curious if other people have suggestions.
Yeah, thank you. And we did have someone from Colorado Access mention from the previous question, as far as PPE, they did say that they have continued to provide home care services with providers wearing full PPE, and they do also provide life alert lanyards for their members. So that's good to know. And yeah, thanks, Evan, for that information. Let's see. Okay, another question. There's a growing concern for seniors who are needing to still work and are furloughed or were recently laid off. What can organizations do to ensure seniors have access to employment resources post-COVID? And this is kind of open to our speakers or anyone that would like to pipe in, especially if you have connection with employment resources.
I will say, I think this is a really good question. This isn't my area of expertise, but I do think that this is something that as a community and at the administrative level, we really do need to be thinking about, how are we going to support older adults who have been kicked out of, or not kicked out, but have left the workforce as a result of COVID-19, because this is a population that is going to have unique stressors and risks around re-entering the workforce. And so, I think that, coming together and, trying to figure out, what are the supports that we can put in place is going to be really key. Again, I'm not, I don't have anything off the top of my head, but I do think it's a really important point and something that should be on the forefront of our minds in the community and also administrators.
Great, thanks, Evan.
Thank you to all of our panelists. Catherine, were you gonna chime in? Was that you?
Just gonna suggest on that employment piece that anyone working with seniors, help them to contact the larger businesses that have remained open during this, such as I notice every time I go into my local Home Depot, there are 2 senior greeters there. So I do think that recognizing seniors as employees offer unique skills and a unique subset to a larger corporation or group like a Home Depot, not just as a greeter necessarily. so helping them to let those larger companies know they're willing, they want to work, they're available. And one of the advantages could be a more flexible work schedule as well. So that's just a couple thoughts I had on that front.
Thanks. Well, thank you again to Catherine, Evan, and Rebecca for your wonderful presentations. I did want to let you all know that our next event of this series is next Wednesday, and this is an incorrect date. So I made the slides right before this. So that's correct for substance use disorder. On the following slide, I entered a slide. We have a seniors group, interest group that also meets. I thought the audience here might be interested in that. It's on May 13th, next Wednesday, but at 1 p.m. And we're going to be hearing from the UC Health Stroke Center, the Colorado Health Institute's Next 50 Initiative grant, and focusing on the senior population during the 2020 census. So you can find that information on our website or outreach me or Joanna, and we can give you that information. In the interest of time, let me see, 1 minute late, but thank you all for joining us today. We'll be sending out an evaluation right now. So please take a few minutes and fill that out for us so we can check how we're doing. Thank you so much.
Thanks, everyone.
Thank you.
Thank you.
Thank you.
Thanks, everyone.